Good evening. Thank you, Annie, for that very kind introduction. So this evening, I'm going to talk about some emerging therapies for autoimmune connective tissue diseases, but I would like to approach it through the lens of autoimmune fibrosing disorders, just to focus the topic a little bit more. I wanted to disclose that I was the recipient of a grant from Pfizer for an investigator-initiated study studying the effects of efficacy of crisaborole for the treatment of morphia. I will also be discussing off-label use of medications. My objectives for this evening were to review some emerging therapies for autoimmune connective tissue disease. I'll give a very brief background on the current state of treatment for morphia, and then talk about some medications that we have repurposed from the field of rheumatoid arthritis. I'll also talk about a medication that has a novel mechanism of action. And I'll end with talking about hematopoietic stem cell transplantation for the treatment of severe systemic sclerosis. So this is certainly not an exhaustive list, but an adequate list of our treatment options for morphia. The topical medications are familiar. Narrowband UVB, PUVA, and UVA1 are reasonable options for phototherapy of patients with morphia. Whenever we reach for systemic therapy for morphia patients, we will usually reach for methotrexate with or without IV or oral corticosteroids. And the second line therapy is usually mycophenolate mofetil. And then, of course, there's a slew of other DMARDs, such as calcineurin inhibitors, tofacitinib, and others that have been reported in case series and case reports to be helpful in the treatment of patients with refractory disease. The research has not been able to catch up with the need, however. There was a Cochrane review in 2019 targeting or really discussing interventions for morphia. However, the authors were not able to do a meta-analysis because of the paucity of the available good quality clinical trials. They did reach two conclusions. The first was that methotrexate was beneficial for patients with morphia, mainly because when they reviewed the data, children and teenagers with linear and generalized morphia had improvement when they were given methotrexate together with prednisone rather than prednisone alone. Their second conclusion was that children and adults with active morphia could benefit from ultraviolet light therapy, and they noted a similar reduction in disease activity or damage with medium dose UVA1, low dose UVA1, and narrowband UVB. They cautioned, however, about the low quality evidence included in their review, and that they included studies which were at high risk of performance, detection, attrition, and reporting bias. Hydroxychloroquine, although commonly used in dermatology, has not been proven in or at least there are no published prospective studies that have demonstrated its efficacy. There was a retrospective study of 85 patients that was published in 2019, where most of the patients included in this study had at least a partial response when given hydroxychloroquine for monotherapy for their morphia. However, the median time to initial response was 4 months, and the median time to maximal response was rather long. It was 12 months. What about mycophenolate mofetil? There was a multi-center retrospective cohort study of 77 patients with morphia from 8 institutions who were treated with mycophenolate, and these patients had failed other treatments, and many of those included in the study were taking other treatments together with their mycophenolate. At 3 to 6 months and 9 to 12 months, at least close to 90% of these patients had stable or improved disease, and 35% achieved disease remission at the completion of this study. For juvenile localized scleroderma, or in the pediatric population, there was a retrospective longitudinal study that came out of Italy that compared patients who received methotrexate versus those who received mycophenolate mofetil. And these patients were treated with mycophenolate, had failed methotrexate and steroids, and 54% of them actually were using methotrexate in combination with their mycophenolate mofetil. After a mean follow-up of 9.4 years, 90% of patients on mycophenolate and 100% of patients on methotrexate had inactive disease. And overall, mycophenolate was well tolerated. Now, going to medications that are initially approved for rheumatoid arthritis, but are finding their way into the more dermatologic applications, no group of medications has received more attention than perhaps the JAK inhibitors. There are several FDA-approved and non-FDA-approved JAK inhibitors that are in the pipeline. The most familiar to us is probably tofacitinib. And ruxolitinib has also been approved for acute GVHD and is on priority review for chronic GVHD. These medications are oral medications, or at least most of them are oral medications that inhibit the Janus kinase enzymes and therefore inhibit the JAK-STAT pathway, which is important in a variety of autoimmune and inflammatory disorders. There are numerous case reports and case series reporting efficacy in the treatment of a variety of connective tissue diseases. And there are several ongoing studies investigating this as well. We have to remember the side effects, specifically opportunistic infections, secondary malignancies, lymphoma, EBV, lymphoproliferative disorders, and more significantly and more recently identified was the risk of thrombosis, especially with tofacitinib, but it's also true for some of the other JAK inhibitors. Patients who were receiving higher doses at 10 milligrams twice a day of tofacitinib were at risk of pulmonary embolism and DVT, as well as arterial thrombosis. In February 2021, the FDA issued a special warning for tofacitinib, reporting adverse cardiac events and the risk of malignancy. Specifically, patients who had rheumatoid arthritis who were treated with tofacitinib, who were 50 years of age or older, with at least one cardiovascular risk factor, were at higher risk of all-cause mortality with tofacitinib compared to those who were receiving TNF inhibitors. There was an open label study of 10 patients with refractory dermatomyositis that was conducted. All patients in the study had at least a minimal improvement or achieved their endpoint, and 50% of these patients had moderate improvement. The authors noted a mean change in the CDASI score from baseline to 12 weeks, which was significant. They also had a decline in their circulating CXCL9 and CXCL10 levels. 3 patients had skin biopsies, and the authors demonstrated a decrease in STAT1 signaling and suppression of the interferon target gene expression after treatment with tofacitinib. I always like to check whether or not there's a dermatologist included in the study when they're evaluating skin, and I did not identify a dermatologist as one of the co-authors as a co-author in this study. There was a double-blind randomized placebo-controlled phase 2 trial of baricitinib for systemic lupus erythematosus. There were 314 patients treated with either placebo or 2 milligrams or 4 milligrams of baricitinib. At week 24, there was resolution of the SLEDAI-2K arthritis or rash in the 4 milligram group, which was statistically significant compared to placebo. That was not true for the 2 milligram group. There was no improvement of CLASI among the patients enrolled in this study. However, Drs. Worth and Merrill noted in their editorial that patients who were grouped together for the analysis were grouped together regardless of their baseline CLASI score. The starting entry score the entry score was also rather low. It was 4 when you want a more moderate score, around a moderate disease activity or a score of around 10 for these patients, if you're evaluating efficacy. So abatacept is another treatment that has been approved for rheumatoid arthritis, also making its way to some more dermatologic applications. It is a fusion protein of CTLA4 and immunoglobulin, and it's given as an IV infusion or a subcutaneous injection. It interferes with the co-stimulatory response or interaction between CD80-86 and CD28, because CD80-86 is more likely to bind to CTLA4. It therefore abrogates the proliferation, differentiation, and effector function that you would normally expect after a successful antigen presentation to a T cell. The main symptoms that are usually described are GI symptoms. Infection is also a major side effect to consider, although they noted that among rheumatoid arthritis patients, the risk of infection seems to be lower in abatacept compared to infliximab, and the risk of infection in abatacept was comparable to the risk with adalimumab and etanercept. There's a risk of reactivation of tuberculosis, so you have to screen for that if you're going to treat your patients with abatacept. And more than 50% of these patients will form anti-drug antibodies. There have been case reports of drug-induced subacute cutaneous lupus appearing after the treatment of abatacept for rheumatoid arthritis. There was a multi-center cohort study that looked at the efficacy of abatacept for refractory morphia. There were 16 pediatric patients enrolled in this study, or 16 pediatric patients included in this study, although some of them were evaluated retrospectively, whereas some of them were evaluated prospectively. These patients had failed mycophenolate or methotrexate and steroids, and were then treated with IV or subcutaneous abatacept. At 12 months, 83% of their patients had a response, and there were no serious adverse effects noted. There was a randomized phase 2 treatment delayed start trial for dermatomyositis that was published in 2018. 42% of the patients in the study achieved their primary outcome. They also noted that those who started abatacept early had lower disease activity at 3 months versus those who did not start the medication yet. There was no statistically significant difference or change in the cutaneous visual analog scale for dermatomyositis at the end of treatment. However, they did not do a CDASI, and there was no dermatologist involved in this study. I also wanted to talk about one medication, actually just one medication with a very novel mechanism of action. And this medication is lenabasum. It is a small molecule agonist to the cannabinoid type 2 receptor. It is orally administered. The cannabinoid type 2 receptor is an inducible G-coupled receptor, which is non-immunosuppressive and non-psychoactive. It is expressed in activated immune cells, fibroblasts, muscle, and endothelial cells. Dr. Worth has actually done a lot of pioneering work with lenabasum. She and her group demonstrated that in dermatomyositis patients, there was an upregulation or increased expression of this cannabinoid type 2 receptor in both the skin and blood of patients, and that there was actually a more robust expression in the skin compared to blood. This is thought to have anti-inflammatory and anti-fibrotic effects. And also from the work of Dr. Worth, they demonstrated a reduction in levels of interferon gamma in dermatomyositis patients after they were treated with lenabasum. This drug has received orphan drug and fast track designation for systemic sclerosis and dermatomyositis from the Food and Drug Administration. There was a randomized double-blind placebo-controlled phase 2 study that involved adults with diffuse cutaneous systemic sclerosis who had disease activity of 6 years or less and who had stable disease on standard of care treatment. These patients were randomized to lenabasum or placebo treatment. Their primary outcome was better in the lenabasum group, and there were no serious side effects. The the patients who were treated with lenabasum had a bigger change or improvement in their modified Rodman skin score and their systemic sclerosis patient-reported outcome, and also in their itch. They actually took biopsies before and after treatment and looked for inflammatory and fibrotic signatures, gene signatures in their specimens. And they found that in patients who were treated with lenabasum, both the inflammatory and pro-fibrotic gene signatures in their specimens improved after lenabasum treatment. Unfortunately, they just announced or recently announced that they failed to meet their endpoint in their phase 3 trial. And as far as I know, this data has not yet been published. So finally, I want to talk a little bit about hematopoietic stem cell transplantation for autoimmune diseases. As you all know, bone marrow transplantation is a life-saving treatment for many patients with hematologic malignancies. However, its use in the treatment of severe autoimmune diseases has also been explored for decades. The principle behind it is this: patients receive high-dose chemotherapy with or without total body irradiation to eliminate and erase the existing malfunctioning immune system. Patients are then given a rescue of stem cells, either an autologous infusion from their own cell, the patient's own cells, or an allogeneic stem cell transplant where from another donor. If engraftment is successful, the patient basically has a reconstituted or a reset immune system. However, the risk of complications is significant. There's a risk of severe infection, death, and in patients receiving an allogeneic transplant, graft versus host disease. The SCOT trial was an NIAID sponsored multi-center trial where which was a randomized open label phase 2 trial involving adult patients with systemic sclerosis of 5 years duration or less, with severe disease, meaning renal or pulmonary involvement. And patients were randomized to receive either an autologous transplant or 9 pulses of cyclophosphamide. And they followed all these patients to the end of the study, which is when the last enrolled patient completed 54 months of follow-up. In the end, they had enrolled 75 patients into this study from 2005 to 2011. Their main outcome measure, which was the global rank composite score, which was a composite of multiple disease manifestations, was better among the auto transplant patients compared to the cyclophosphamide patient. And for their per protocol analysis, and that's this number here, this is per protocol, and this is intent to treat analysis, the overall survival, event-free survival was much better in the auto group compared to the cyclophosphamide group. The durability of response was also better after auto transplant, with only 9% of the patients who received autologous stem cell transplant requiring a DMARD rescue at 54 months post-treatment. There were 2 patients in the transplant group that had a treatment-related mortality. These patients developed myelodysplastic syndrome and died. There were no treatment-related mortalities in the cyclophosphamide group. In their secondary outcome measures, you also noticed that there were more patients in the transplant group who had improvement of their modified Rodnan skin score compared to the cyclophosphamide group. So because of this, autologous stem cell transplant, hematopoietic stem cell transplantation is now part of the standard of care for severe systemic sclerosis at many institutions, including at Duke. So in summary, there's still a great need for effective and safe treatments for autoimmune connective tissue disorders. We talked about some new therapies, including JAK inhibitors and a non-immunosuppressive therapy, lenabosum, and these are promising treatments for autoimmune connective tissue diseases. We also talked about how autologous hematopoietic stem cell transplantation has been shown to be effective in the treatment of severe systemic sclerosis. However, the efficacy and safety of hematopoietic stem cell transplantation in the treatment of other autoimmune connective tissue diseases remains to be seen. So I'll stop there, and I didn't want to end without thanking the Dermatology Foundation that has supported and advanced my career, the Duke Scleroderma Transplant team, my different funding sources that have allowed me to continue to study, continue my interest in autoimmune fibrosing disorders, and to the organizers of this meeting, especially to Debbie Kovacs for all her hard work, not just for this meeting, but for all the activities of the Medical Dermatology Society. And I wanted to thank all of you for your very kind attention.